everyone. I'm Jennifer Walsh, a Senior Media Officer with the Institute of Medicine. Thank you for joining us this morning for the public briefing to release the new Institute of Medicine report toward quality measures for population health and the leading health indicators. For those of you not familiar with the IOM, it is an independent nonprofit organization that works outside of government to provide unbiased and authoritative advice to decision makers and the public. It is also the health arm of the National Academy of Sciences. For each requested study, panel members are chosen for their expertise and experience and serve pro bono to carry out the study statement of task. The reports that result from the study represent the consensus view of the committee and must undergo external peer review before they are released, as did this report. I have with me several members of the committee to discuss the report's findings and recommendations, but before we introduce the committee, I just want to go over a few technical aspects of this webinar. First off, the audio for today's event will be streamed through your computer speakers. After the opening remarks, we will take questions through the Q&A box located in the lower right-hand corner of your screen. When it is time, simply type your question in the box and click Submit. We ask that you leave the box set to send your questions to the all panelists. And also, if you have any technical issues during the event, please contact the WebEx technical support at 1-866-229-3239. Again, that number for the WebEx technical support is 866-229-3239. Now we'll introduce today's webinar participants. Joining us first is Dr. Stephen Teutsch, Chair of the Committee and Chief Science Officer at the Los Angeles County Department of Public Health. We also have Gib Parrish, an independent consultant at the Public Health Informatics Institute. Also Greg Randolph, Director for the Center for Public Health Quality and a Professor of Pediatrics and Public Health at the University of North Carolina at Chapel Hill. And finally joining us is Pierre Vigilance, Associate Dean for Public Health Practice and Associate Professor of Global Health at the School of Public Health and Health Services at George Washington University. And Pierre can only be on the call till about 11:30, so if anybody has any questions for him early on, please ask those up front. Also joining us is Alina Bachu, Study Director for this report. We'll start off with Dr. Teutsch giving some opening remarks, summarizing the report's findings, and then I'll open it up to any questions you have. Please note that this briefing is scheduled to last 1 hour unless we run out of questions beforehand. And with that, I'll turn over to Dr. Teutsch.
Thank you very much, Jennifer, and thanks to everyone for joining us this morning. Jennifer told you a little bit about the Institute, and I will talk to you a little bit about the report. This study was commissioned by the Office of the Assistant Secretary for Health and the Department of Health and Human Services as part of their ongoing effort to improve the quality of public health in the United States. They gave us a charge, which you can see here, which is to use the 9 aims for improvement of quality in public health. You can see what those are, being population-centered, equitable, proactive, health-promoting, risk-reducing, vigilant, transparent, effective, and efficient, as a framework for identifying quality measures for the leading health indicators, which are part of healthy people. The first part of our charge was to review the existing literature on the 12 leading health indicators topics in the 26 LHIs themselves, to identify quality measures for them that are aligned with those 9 aims, and then to note alignment with the 6 priority areas for improvement of quality in public health. For those of you who may not be familiar with those priority areas, those include population health metrics and information technology, evidence-based practices, systems thinking, sustainability and stewardship, policy, and public health, workforce, and education. The last part of this section was to address data reporting and analytic capacities that must be available to capture the measures and for demonstrating the value of those measures to improving population health. The second part of our charge was then to provide recommendations on how the measures could be used across sectors of the public health and healthcare systems. This is a list of the committee members. It was a very diverse and highly skilled group that deliberated over 2 meetings and multiple phone calls and offline exchanges. So let me just take a moment to talk about how the committee approached the charge. It began by developing a logic model to guide the measure identification, and then developed a set of criteria for actually selecting specific measures. One of the things that the committee noted was that we needed to develop a system for the ongoing management of a system of measures. And so we talked about the aspects of what such a system might look like, and you can see some of the characteristics there. We talked about the need for a measurement endorsement process so that we had an appropriate list that was well recognized as being as meeting those criteria. And then we described the potential uses and the variety of users of these measures. As I'm sure all of you know, that the public health system and the healthcare delivery system in the U.S. really share a common goal, which is recognized in Healthy People 2020 and in the Affordable Care Act, and that is that we want to achieve long, healthy lives for all. And you know, in order to do that, quality is an important characteristic of the multisectoral health system it will enable it to achieve that goal. Most of you are aware that quality to date has largely focused on quality within the healthcare system, and you know, that's a legitimate focus of the national conversation. But what's been missing to a large extent is one that deals with the population health and the health of the public more broadly. The committee used the definition of quality in public health that was developed by the Public Health Quality Forum, which is the degree to which policies, programs, services, and research for the population increase the desired health outcomes and conditions in which the population can be healthy. When we speak of the multisectoral health system, this is what we are talking about. If you look at the diagram on the right side of your screen, you can see that this is coordinated by the governmental public health system and the public health infrastructure, but the system itself includes a wide variety of stakeholders, including the clinical care system, employers in business, other government agencies, the multiple sectors, illustrated here by education, but we could add housing, transportation, and criminal justice, the media, community, and so forth. And the reason we have all of these players is that health is actually shaped by multiple stakeholders and multiple interacting factors, all of whom contribute to creating the health of the nation. And the first recommendation from the committee is actually harkens back to the important report from several years ago called Crossing the Quality Chasm, which laid the framework for quality improvement in the clinical care system. And that recommendation now, as adapted for population health, is that the committee recommends that all partners in the multisectoral health system adopt as their explicit purpose to continually improve health outcomes of the entire population and the conditions in which people can be healthy. And the extent to which this purpose is achieved reflects the overall quality of the health system. The committee found that the partners in the multisectoral health system currently struggle because there are a vast and complex array of measures of quality, and they are being used in a manner that seems largely uncoordinated. To deal with this problem, the committee developed a suite of 4 recommendations that I will run through for you. The first of those is that the committee recommends that Health and Human Services, HHS, and its partners in population health improvement adopt a portfolio of measures of the quality of the multisectoral health system. And that portfolio of measures should include summary scores, which reflect population-level healthy outcomes and healthy conditions. It should balance parsimony with sufficient breadth, always a challenge, and to inform assessment, improvement, and accountability within the entire multisectoral health system. The committee reviewed a number of sources that have looked at criteria for selecting quality measures, and those included some from HHS itself, and as it developed the leading health indicators, the National Quality Forum, the Agency for Healthcare Research and Quality, and prior Institute of Medicine reports. But we developed a set of criteria that indicate characteristics that are more relevant for population health, since most of the ones that I just referred to tended to focus on clinical quality measures. And we wanted to make sure that the criteria were useful to a wide range of practitioners, organizations, and sectors that are actually involved in quality improvement. The committee recommended the criteria that you see below, which included two basic constellations of criteria. The first were criteria for conditions or outcomes to be measured. And we felt those needed to be reflective of the important health problems. That is, reflective of a high preventable burden, which means that they're important health problems, and we have effective existing interventions to implement, and that they were actionable at the appropriate level for intervention. Then we had a set of criteria for the measures themselves, that is, that they needed to be available in a timely fashion, usable for assessing various populations, they needed to be intrinsically understandable, they needed to be rigorous methodologically, and then finally they needed to be accepted broadly and harmonized so they were consistent. The third of the recommendations in this suite was to ensure the implementation of a systematic approach to develop and manage a portfolio, that HHS should establish or designate a non-governmental and appropriately equipped entity to endorse measures of quality, so that we had a system of endorsement that we could all accept. And finally, the Department of Health and Human Services should develop, implement, and support data collection, analysis, and dissemination mechanisms and infrastructure for the entire portfolio of quality measures so that they can be used at all levels. In other words, we need to support the infrastructure that is necessary for actually having these data available at the appropriate level and in a timely fashion. This is the logic model that the committee used, which was built largely as a reflection of the work of Donna Bedian, which, of course, assesses structure, process, and outcomes. And it reflects the definition of quality in public health. And what you see on the left are some of the necessary components in terms of resources available to the population health system and capacities, not only including people, training, and funding, but also the research that provides new knowledge for us to use. From there, you, of course, have a set of interventions that are policies, programs, and services that are actually delivered, and hopefully they create the kind of healthy conditions that you see here. And the healthy conditions are that we have a population that has positive health behaviors, that we have access to population health services and quality health care, that there is the kind of social, economic, and educational environments in which people can be healthy, as well as the physical environments in which people can be healthy. With those, that should lead to better health outcomes reflected as long, healthy lives for all. We think that this model is helpful in a number of ways. First, it helps organize our thinking about measures of quality and where they fit. It helps us think about, in a systematic way, the pathways from structure to outcomes and the relationships among causal factors. And lastly, it helps identify the candidate measures for the 12 LHI topics and the 26 leading health indicators themselves. The committee had a large task and limited time, and so given those limitations, we tried to show how the framework that I just reviewed with you could be applied to 4 of the LHI topics to show how that might work in practice. Many of the leading health indicators are actually measures of health outcomes or conditions that can directly affect health outcomes. So in other words, they're actually measures of the quality of the multi-sectoral health system themselves. They can be used for assessment, improvement, and accountability, and they must be relevant and measurable at the requisite level, particularly national, state, and local levels, in order to be useful. The LHIs themselves reflect the kind of conditions or outcomes that contribute to the Healthy People Foundation measures, which are the general health status and health-related quality of life, and the ecologic model that underlies it. So, as I mentioned, we developed 4 case studies to illustrate how specific measures could be developed. And the 4 are shown here: tobacco, maternal infant child health, environmental quality, nutrition, physical activity, and obesity. And I commend the report to you so that you can see how those unfold. I will run through just one very briefly, so at least you get a sense as to how we develop these. So here's the logic model and some of the conditions and so forth that relate to tobacco use. At the top of the figure, you see the resources and inputs, the interventions, the healthy conditions, and the healthy outcomes. And then down below, you see how those apply to the topic of tobacco use. So on the far left, you can see that we have knowledge from research about the effects of tobacco, harmful effects, and what are effective strategies that can be used, as well as the resources that we have available to address the problem. Moving progressively to the right, you see some of the information that's needed from surveillance and programs. You can see the laws and regulations that one can put in place to limit availability and decrease use of tobacco, and then individual and population programs and services. The column under interventions shows the monitoring, again, the surveillance function. You can see the effect of those interventions, increasing the excise taxes and changes in incentives for purchasing of tobacco and the availability of tobacco. And then, of course, some of the programmatic outcomes in terms of providing information and media and other kinds of information. Out of that, we hope to then see the changes in the healthy conditions, which are, as I indicated, the incentives for purchasing tobacco by increasing the costs and decreasing profits and decreasing availability of places to smoke, increasing the numbers of people who successfully quit. Ultimately reducing the prevalence of smoking and the exposure to secondhand smoke that then leads to the healthy outcomes that we ultimately want to achieve, which are about tobacco-related diseases and functionality, increase in longevity and quality of life, reflected here as health-adjusted life expectancy, which is the overarching measure for long, healthy lives for all, and then some other sequelae such as reduced societal costs from tobacco-related problems. Turning to the second part of our charge about using the quality measures, we saw that there were really a great many potential users of the measures of quality. Some of them you see here, and they reflect the multisectoral health system. But in particular, we saw 3 specific uses that we wanted to emphasize. The first was their use in the development of community health assessments by health departments, which are not only something that they generally do, but are part of the accreditation process. The second relates to the community benefit requirements for nonprofit hospitals that grew out of the Affordable Care Act, and the community health needs assessments that they are required to do under the IRS regulations. And finally, the 3-part aim, which is part of what AHHS is leading with CMS, that looks at healthcare and community partnerships and tries to achieve the 3-part aim, which is analogous to the triple aim from IHI. To use those measures in practice, the measures actually have to be available not only nationally and at a state level, but at the level that's relevant to those specific users. And often that means that they have to be available at a local level, and we need the kind of infrastructure to do that. They also need to be able to look at the appropriate subpopulations so that they can be used for improving equity in the kinds of interventions and programs that are put into place. The committee found that the concept of the three-part aim, which is embedded in the National Quality Strategy, should play a growing and important role in establishing population health as an essential area of focus in transforming health care and health in the U.S. And found that additional development is needed by the users of the three-part aim to incorporate evidence-based measures representing social and environmental determinants of health, which are the greatest determinants of our health, in fact, equity, and the concept of total population health. And to that end, the committee recommended that HHS convene stakeholders to facilitate the use of the measures for the multisectoral health system and their integration into all activities under the three-part aim, focusing particularly on the social and environmental determinants, equity, and the concept of total population health. So with that, I'm going to stop. You can see here where you can obtain the report and the brief that accompanies it, and I'll turn it back over to Jennifer.
Okay, thank you. And now we will open it up to questions. Again, if you want to ask a question, if you go to the Q&A box in the lower right-hand corner, type in your question and hit submit to all participants. I ask that when you ask a question, if you can also please identify your organization. Well, it looks like some folks might be queuing up to ask a question. So while we're waiting for that, maybe I'll just get the conversation started. So I'll throw out the first question. What does the committee mean when they talk about the multisectoral health system?
Pierre, that sounds like one for you.
It is, and good morning, everybody. Thank you for that question. We understand that health and health outcomes are not solely under the purview, if you will, of the health system. If it was for just providers and doctors and insurance companies to be solely responsible for health and health outcomes, then we would not be able to move forward in the way that we need to with respect to improving health outcomes for communities. And that makes this a very challenging task then, to try to create quality measures related to public health. And then we understood that as a committee and felt that it was important to not speak specifically just to the healthcare system as we typically speak to it, but to include commentary or use a term that actually embodied and embraced a number of different partners. And those partners include not only the public health systems, or the government public health departments at the local and state level as well as the federal level, but also their clinical partners as the slightly concentric circle outside of them, and then out into areas such as Steve mentioned, such as transportation, housing, economic development, education, the media, and some of these other players that have a major role in framing messaging relating to health, and having policies and procedures in place in locations where people work, play, and pray on a regular basis. These institutions and organizations all have a role to play with respect to health and health outcomes. And so they are included in what we consider the multi-sectoral health system. And we recognize that does create a very large network to consider, but I think that it's important, especially as we look at this logic model at the resources and capacity end of things, it's very important at that input end to have a broad range of inputs from that very diverse system.
Okay, thank you. We now have some questions from some of the participants. I will read them off, and again, I apologize if I mispronounce any names. The first question comes from Stephanie Gleer. She asked, could you please clarify whether you are using public health, population health, and community health to mean different things? If so, could you explain further how you are using or approaching these different concepts?
So this is Steve again. That's an important question and clarification, because I do think we commonly use these terms in different ways. And I think that the committee, when it uses the term public health in general, tends to think about that in terms of the governmental public health system, whereas population health is the more general term that embodies all of the different stakeholders. If you'll notice, we talk about the multi-sectoral public health system when we really want to be more inclusive. In general, we did not use the term community health. We find that, at least I find that a somewhat more idiosyncratic term. But let me ask Gib, because I know he's given a fair bit of thought to the nuances of this terminology.
Thank you, Steve. This is Gib Parrish. I will reinforce what Steve said. I think the committee was in general tried to draw a distinction when we use different terms as to what they meant. The multi-sectoral health system was used when we meant it to be all-inclusive, as Pierre has just described. Governmental public health is meant specifically to refer to the various government agencies that carry out that mission at the different levels of government. And population health, I think you can think of actually in a couple of ways. One is it actually is essentially meant to reflect the health of the entire population, the total population, all population subgroups, and how we view the health of them collectively. So maybe that'll help a little bit with further clarification of the terms.
Okay, we have another question coming in. This comes from Chisara Asamuga. The community health needs assessment would be an important instrument for determining quality and health outcomes. Can you speak some more about how this instrument should be used within the healthcare system and other non-traditional players to improve health?
Yes, and that's indeed what we hope will be accomplished. Greg, do you want to take that one?
Yes, thanks. Hi, everyone. This is Greg Randolph. This point makes note of a very important development recently with the Affordable Care Act that we noted, which is that nonprofit hospitals are now required to do community health needs assessments every 3 years. And as a part of that, they're also supposed to involve public health expertise in their efforts around these assessments, and also justify how they're going to address or not the needs assessments that arise, or the needs that arise from these assessments. So this is a great opportunity for public health departments and other public health organizations and hospitals and other healthcare partners, as well as other community partners, to work together on assessing the needs in the community, as well as then making improvement plans to address those needs as a group together. So we would envision that the development process and the quality measures that come from them, from this report, should facilitate this process, and in particular having outcomes that would be relevant to these community health improvement efforts.
Thanks, Greg. Let me add, since we're looking forward to seeing those needs assessments from many not-for-profit hospitals, and we have community health assessments also from public health departments, we are looking forward to seeing a level of harmonization, so we don't end up with a chaotic set out there of people of measures that can't be compared. So we believe that the process that we've described can lead to an ongoing and continuous set of relevant measures that can form as a core set that are used by all of these different stakeholders and groups that are going to be doing these needs assessments.
Thank you. At this time, we have no more questions that are coming in. Again, if you have a question, please type it into the Q&A box in the lower right-hand corner and hit submit. In the meantime, I'm going to throw another question out to the committee. Can you talk a little bit more why the committee didn't offer a specific set of measures in its report?
Yes. So this is Steve again. And I think there were a number of reasons. One is when we received our charge, we also talked about laying the groundwork for quality improvement within the public health system and the population health system over time. And rather than coming up with a static set of measures that would be a one-time stake in the ground when we have many other sets that are already out there, we thought it was important to develop a process whereby one can have a dynamic set of measures that and build a system that will allow that to maintain that over time. The other reason was that perhaps it was a bridge too far for us. We had 2 meetings in 6 months to develop measures for all 26 LHIs. Required a level of expertise and research that we didn't feel we could accomplish as successfully as we would need to over that period of time. Hence, we developed some of those models for those 4 topics that I mentioned to you. And for those of you who are downloading the report, you can see, I believe it's Table 3.1, where we show what indicators might look like for each of the quality measures would look like for each of the LHIs, meant to be illustrative rather than definitive. But those are the primary reasons why we didn't actually develop a single set of measures.
Thank you. At this time, we have no more questions, so I'm just going to kind of throw a last question out to the committee. How would you say that these measures are different from the health care measures everyone is familiar with?
I'm sorry, Jennifer, could you repeat the question?
Actually, we just had another question come in from someone else, so we can get back to the question I had. This is from Ann Carroll. She asked that given the current fragmentation of the public health functions across federal agencies and their state counterparts, do you see any particular areas where this new restructuring is needed?
I don't know if any of my colleagues want to take that one on. This is, I think you're talking about the need to get better integration. There were certainly many initiatives to bring that kind of coordination into place, as we see in the Prevention Council and the National Prevention Strategy. But this wasn't a topic that the committee spoke to at great length. So I don't know if any of my colleagues on the phone want to speak to this.
Steve, this is Greg, and I don't know if will directly address the question, but one thing I did think of that we did talk about in the report is the real opportunity that the 3-part AIM provides, and one of the, it's basically better, improved care, reduced costs, and improved population health. And we did see that as an opportunity, with that being embedded in a lot of national policy, including the National Quality Strategy, for public health departments, other public health groups, and their healthcare partners and others to work together around that 3-part AIM, which has been a big I guess, movement in healthcare with the IHI's triple AIM work. So we did see the 3-part AIM as a nice way to, I guess, break down some of the silos and come together and work on mutually beneficial aspects of the 3-part AIM, which in this case would be for public health and healthcare, the population health improvement AIM. So that was one thing that kind of made me think about the fragmentation issue that can help break that down.
And if you look in the logic model, again, this is Steve, you'll see that we devote a lot of time to these healthy conditions, which are really about, can only be created with a successful partnership with many of the stakeholders in other sectors. And you're probably aware there's a substantial movement. There have been recent IOM reports that talk about the need for health in all policies, to think about not just health as the sum of the health of individuals, but also about healthy communities. I refer you back to the 3 reports on public health strategies that are on measurement, policy laws, and public health financing that talk about that, as well as the NRC report on health in all policies and health impact assessment.
Okay, and at this time I'll go back to the question I asked you earlier before we got Ann's question. How would you say that these measures are different from the healthcare measures everyone is currently familiar with?
They're different in some very fundamental ways. The clinical measures are very much about things that happen within the clinical care system, and the measures that we're talking about largely are at the population level. So, just to take some simple examples, you have measures used within the clinical care system about whether physicians and other practitioners are providing counseling for tobacco cessation, inquiring about smoking, offering services, and so forth. But on the population level, we're very much interested in the laws that are in place, whether they be taxes, whether they be banning smoking in public areas, like in clean air laws, enforcement of those kind of laws, and so forth, that are more at the population level and are actually, rather than looking at just the sum of the individuals, we'll look at overall, what are overall smoking rates in different parts of the population and so forth. In addition, we have measures about healthy conditions that fall out of the traditional healthcare arena, or if you might think of the health arena, which relate to things such as education, income. So we'll look at graduation rates, percentage of the population below the federal poverty level, and many other measures that go well beyond what one traditionally thinks about as part of the clinical care system. Gib, Greg, Pierre, do you have anything you'd like to add?
No, this is Gib. No, I think you covered it well, Steve. Thank you.
Yes.
And we have another question that came in from Chisara Asumoga again. It says, it sounds like then that the population health measures are looking at the impact of larger policy efforts that address health.
That's correct. Obviously, we need the individual level services and so forth to deal with health issues, but I think it's fair to say that the most powerful policy levers we have for improving health actually lie in the policy arena and lie in other sectors, because those are largely the things that determine health. So that we are looking very much at measures that affect the population broadly, that are measures of health in the population broadly, not just those within the clinical care system. I alluded in my presentation to total population health, which is thinking about population at a geographic level. And if you think about what is the health of those people, you can see that within that geographic area, there are important subpopulations. And the subpopulation may be the patients who are part of a clinical care system. But that only represents a subset of the overall population. So we have many subpopulations that you can be defined by who provides their care, or who their employer is, or they are in a certain school system. But we need to think of the population in its entirety so that we can address the needs most broadly, have the kinds of programs and policies that affect them in their entirety, and then those should also address the issues associated with equity and across the population and reduce disparities.
Well, thank you. It looks like those are all the questions that we have for today. I just want to remind everybody that you can download a free PDF of the report now at www.nap.edu. And again, on the slide in front of you, if you visit www.iom.edu/quality measures, you can get a copy of our report brief as well as the slides that were used in today's presentation. And we're also going to attempt to put up a recording of today's webinar as well. Thank you all again for joining, and hope to hear from you soon.